our KNHUN A Project Symposium on Primary Immunodeficiency Disorders. I can see we are nearly 300 participants, and most of our team is here. So today we are privileged to have a team of two esteemed presenters. But first, I'll give an introductory of what we are doing. So we have the Primary Immunodeficiency Disorders Symposium that will be going on for the next 3 days. The theme is Towards Better Awareness, Early Diagnosis, and Optimal Care. It's a 3-day online symposium that will be on Tuesday, Wednesday, and Thursday. Starting at 7 p.m. up to 8:30 p.m. Shall be having a myriad of esteemed presenters, specialists in their field. First of all, I want to thank the organizers of this symposium, Dr. Ann Barasa, Dr. Migoa, Dr. Walong from the A Project, and also Dr. Kinuthia and the whole KNH team for giving us a platform of where we can do this. So as I'd said, it's a 3-day symposium starting today, Tuesday, 7 p.m. We're starting at 7:05. We'll have a brief overview and a clinical spectrum of PIDs. On Wednesday, we shall do the lab approaches. On Thursday, we'll have common variable immunodeficiencies and also multidisciplinary approach, and a closing remark from Professor Nduati, who I can see is part of the team. So what is the A Project? The A Project is an educational program by the African Society of Immunodeficiencies, aimed at improving the awareness to PIDs. So I will introduce our panelists for today. We have two, so I'll introduce the first panelist and I'll introduce the second one. Our first presenter and panelist is Dr. Ann Barasa. She is a pathologist and a lecturer in the University of Nairobi, Department of Human Pathology, the thematic head of immunology. Her clinical research and interests are in the immunopathology of immune deficient states and pathology of viral mediated malignancies, focusing on strategies of vaccine development against gamma herpes viruses. Dr. Barasa has also actively participated in international advanced primary immunodeficiency diagnostic schools, and is also involved in teaching, educating, and creating awareness on primary immunodeficiency disorders in Kenya via the A Project. So Dr. Barasa, you have 30 minutes. The floor is yours. Say hi to the team and let's start us off. Thank you.
Good evening, everyone. Thank you for taking time out of your day to attend this webinar. So I hope my slides are visible.
Yes, they are. You can start.
Okay, so I'll take us through an overview of primary immunodeficiency disorders, or as purists prefer to call them, inborn errors of immunity. So this is the outline of my talk: and introduction, epidemiology, classification, pathogenesis and clinical features, approach to diagnosis, principles of management, prognosis, and then I'll just have a small section highlighting what we can do to identify patients with inborn errors of immunity. Just give me a second. I think my slides are like, the timer is pre-recorded. I need to stop that. Sorry about that. Just 1 second.
So as Dr. Barasa tries to sort that out, I want to recognize the presence of Dr. Walong, one of our panelists during this continuous session. Professor Nduati shall be joining us later on. Dr. Anne-Marie Masharia shall be presenting also. And also Cleophas Mutua shall be presenting also at a later date. If you have any questions, comments, kindly put them in the Q&A section. Shall be also moderating the Q&A session, so you can be posting them in advance. Dr. Barasa, thank you. Continue.
Okay, so inborn errors of immunity are a heterogeneous group of disorders which are attributed to genetic errors which impair different components of the immune system. And this involves both the innate and adaptive immune system. They present with an increased susceptibility to infections. We know the major role that our immune system plays is to protect us against foreign microorganisms. But we also know when you have an abnormality with immune responses, it can either be a deficiency or exaggerated immune responses. So inborn errors of immunity can also present with predisposition to autoimmunity, to autoinflammation, to atopy, and to malignancy. So just to remind ourselves of the components of the immune system, we have both cellular and humoral components. So cellular are the cells of the innate immune system, mainly the granulocytes and the natural killer cells. The phagocytes, which are also the antigen-presenting cells, and the cells of the adaptive immune system, which are the lymphocytes, both the B and the T cells. And it's the antigen-presenting cells, which are cells of the innate immune system that bridge or connect the innate and the adaptive immune systems by presenting antigens. The innate cells of the innate immune system usually recognize antigen using, or foreign pathogens using what we call pattern recognition receptors. And they recognize what we call pathogen-associated molecular patterns. And that's how these antigen-presenting cells will be able to take up these foreign pathogens, break them up into peptides, and present that antigen to the T lymphocytes. Specifically, T lymphocytes are not able to recognize these microbes in their native form. They have to be presented in form of antigenic peptides. B cells can recognize antigen directly. And for the cells of the adaptive immune system, they recognize antigens using a receptor. So either the B cell receptor, which is an immunoglobulin that is attached on the surface of the B cell, or the T cell receptor. And the adaptive immune system is able to recognize a diverse number of antigens because during the development or maturation of the B and T lymphocytes, one of the key features is rearrangement of the genes that code for these receptors, so that that enables us to recognize a diverse number of antigens so that we can respond to as many foreign pathogens as possible. For the humoral components, these are soluble molecules, so things like cytokines, antibodies, and complement. So as at now, we have about 430 distinct inborn errors of immunity, which are defined by single gene defects. Most of them are diagnosed in childhood. About 40% are diagnosed in adolescence or early adulthood. And this is just a chart with data from the South African Primary Immunodeficiency Registry. Just highlighting this fact, we can see that most of the disorders were diagnosed in early childhood between 0 and 5 years of age. And with increasing age, you have fewer disorders being diagnosed. But this is just to highlight that these are conditions that you may see in adolescents or you may see in adults. It's not only a problem of children. When it comes to the epidemiology of inborn errors of immunity, when you take each of the gene defects on its own, they're relatively rare. But taken as a whole or combined, when you take all the 430 gene defects, then they're more common than previously thought. So it's thought that the collective prevalence is ranges between 1 in 1,000 to 1 in 5,000 persons. And the reason why we are recognizing them more and more is because of ongoing discovery of new inborn errors of immunity. And of course, this is because of advances in molecular diagnostics, especially with next generation sequencing. So we can recognize newer mutations in some of the genes that code for components of the immune system. And then also the improved definition of the clinical phenotypes has led to the increasing collective prevalence of inborn errors of immunity. The other thing is that also the prevalence also varies depending on the type of immunodeficiency, and we'll go through the types in terms of classification. So for example, a condition like selective IgA deficiency is relatively common. The flip side is that most of the patients tend to be asymptomatic, so it still may not be picked up. So the prevalence of that, for example, ranges from 1 in 200 to 1 in 1,000, whilst severe combined immunodeficiency, which is one of the most severe forms, is quite rare, with a prevalence of 1 in 58,000. So overall, it's been shown that about 70 to 90% of individuals who are living with an inborn error of immunity either remain undiagnosed and or untreated. And this is especially so in resource poor areas. And here we're talking about access to medical care or sophisticated medical care, and also laboratory resources for diagnosis. In Africa, it's thought that there may be up to 900,000 people living with an inborn error of immunity. However, only 1,000 are currently registered. So those are the cohorts that are being followed up, whether or not they're still alive to date. And the registries are mainly seen in countries that are more advanced in terms of primary immunodeficiency care. So that's in Northern Africa, including Sudan, and then in South Africa. In Kenya, the prevalence is unknown, but we do know that we have these cases. We've come across quite a number. There are, at least I know of 2 case reports published, but there are more cases that have been presented in scientific fora, and we'll get to hear about some of these cases. So it's likely that we're either missing the diagnosis or we are underdiagnosing them. And this could actually be because of the high burden of infectious disease that we are facing. So we tend to attribute these recurrent infections probably to these infectious diseases, or the fact that we may be encountering these patients with this recurrent, persistent, severe or unusual infections, and we are treating them, but we're not really thinking about the fact that there may be an underlying cause. So we're not investigating these patients further. So the classification of inborn errors of immunity is performed by an expert committee of the International Union of Immunological Societies, and they update this every year. This is every 2 years, sorry. This is the most recent update of 2019 that was published this year. So they stratify the inborn errors of immunity into 9 categories, and these are based on the underlying immune defect. And then, so it's quite an extensive classification. So they've also come up with a phenotypic classification that makes it easier for clinical use, so that we can be able to classify our patients based on the clinical phenotypes. So that is the clinical manifestation as we see them, the signs and the symptoms, as well as the laboratory phenotype. So what abnormalities are we picking up from laboratory investigation? This the 9 groups, which I'll just briefly mention. So all the 430 single gene defects fit within these 9 groups. So the first one is what we call the combined immunodeficiencies. So these are immune deficiencies that affect both the cellular and humoral immune systems. So this is T and the B lymphocytes. And the broad categories under this are severe combined immunodeficiency. This is defined by T-cell lymphopenia, which is basically an absolute count of T lymphocytes of less than 300 cells per microliter of blood. So that's the first major group. And then we have 2 other groups of combined immunodeficiencies, which are less severe than SCID. And then a third group of combined immunodeficiency that is associated with syndromic features. So things like your DiGeorge and so forth. The second broad category is predominantly the antibody deficiencies. And here, phenotypically, these are categorized as basically low serum IgG, IgM, and IgA, in addition to the B cell count. So if the B cell count is low, which is less than 1% of the circulating lymphocytes, or absent, that would be classified as an agammaglobulinemia. if the B cell count is normal, meaning more than 1% of the circulating lymphocytes, then that will be classified as a hypogammaglobulinemia and likely a common variable immunodeficiency phenotype. And there are several disease conditions under that. And then the other major group would be isotype or other functional deficiencies. The third group are diseases of immune dysregulation. We know when we cannot regulate our immune system, then we'll either have lymphoproliferative disorders or we'll have autoimmune disorders. So these tend to present in that manner. The fourth group are congenital defects of phagocyte number or function. So the number would be the neutropenias, like a congenital neutropenia. In terms of function, it's either defects that will cause or interfere with the inflammatory processes that lead to addition and chemotaxis of your neutrophils from the blood into sites of infection. Or that may be okay, but we have an abnormality or a defect in the oxidative killing of by the neutrophils, for example, in chronic granulomatous disease. There are two groups I've repeated. There's a repetition there of defects in intrinsic and innate immunity. That's one group. This mainly affects the natural killer cells and other aspects to do with recognition by innate immune cells. For example, a defect with the toll-like receptors, and they tend to present with recurrent severe either bacterial, viral, fungal infections, and so forth. And then we have the autoinflammatory disorders, which are rare, but as the name suggests, there's unexplained or excessive inflammation, for example, in familial and Mediterranean fever. Then we have the complement deficiencies, and these can either present with increased risk of infection or autoimmune-like phenomenon, for example, with the early components of the classical pathway of complement. A deficiency can lead to an SLE-like syndrome. And then we have the bone marrow failure syndrome. So all these conditions we cover in hematology, like your dyskeratosis congenita, Fanconi anemia, and I'm aware that we have a cohort of Fanconi patients at KNH. Those are now considered as inborn errors of immunity. And the final group is the phenocopies of inborn errors of immunity. So these are conditions that present in a similar fashion. In terms of the phenotypic manifestation, they present as IELs, but the underlying pathology is either a somatic mutation or a presence of autoantibodies that lead to the manifestations. So those are the 9 major categories. When it comes to the distribution in terms of the categories, the spectrum varies. And this is majorly determined either by regional consanguinity and individual hereditary patterns. So because we say these are single gene defects, the inheritance patterns vary. Some can be inherited in an autosomal dominant fashion, some in an autosomal recessive fashion, and some in an X-linked fashion. However, overall, antibody or B-cell defects make up majority of the inborn errors of immunity, as shown in this pie chart. And of these, the common variable immunodeficiency phenotype is the most common. And just like SCID, CVID is not just one disease, there are many underlying causes. So this is a table from the Jeffrey Model Global Report on Primary Immunodeficiencies. So here they've taken data from different centers of excellence in primary immunodeficiency from different parts of the world, just to see the trends. And this is just to show that predominantly from the USA registries, we have mainly antibody deficiencies. And globally, when they look at every other country that has a registry, it's antibody deficiencies which predominate. There's a category that says unspecified or other deficiencies. Probably this one not fully worked up because this information was reported by physicians. When it comes to studies in Africa, as I mentioned, there's a lot of primary immunodeficiency work that's going on in Northern Africa and in South Africa. And one of the things that is glaring from this review and from this table is that the rates of consanguinity are quite high in the Northern African countries, and that may probably change the spectrum of disease that we see in countries where we have high rates of consanguinity. However, we still have a predominant antibody deficiency, for example, here from a study done in Egypt. But you can see this is not as high in terms of the proportion compared to to North America, which was about 57%. In Morocco, it's the well-defined immunodeficiency syndromes that predominate. So syndromes, as you know, would imply that there are other body systems that are involved, not just the immune system. In Tunisia, we also have a predominance of combined immunodeficiency and not the antibody deficiency. So that's T and B cells. But we can see that in South Africa, this mirrors what is seen in North America and also from the European registries, where it's the antibody deficiencies that predominate. And of note is that from the South African PID registry, there was no consanguinity reported, but there's a strong family history positivity of about 30%. So when it comes to the pathogenesis, as I've mentioned, these are gene defects, so they are monogenic disorders, and these are germline mutations, unlike the somatic mutations that we see in the phenocopies of inborn errors of immunity. So either we'll have a loss of function or a gain of function of the encoded protein, but the bottom line is that the function will not be normal. So most arise from abnormalities in cellular maturation. This figure on the left just summarizes our hematopoiesis and development of the blood cells or the immune cells for us. And the consequences of the defects will depend on the stage of development that's affected. So as I mentioned, the defects can either be in the signaling pathways, transcription molecules, or cytokine pathways. Remember, as our stem cells differentiate and proliferate into the different effector cells, these cells receive communication signals to either continue differentiating or if they don't receive signals, then there'll be an arrest in differentiating. So these signals are things like growth factors, cytokines, and so forth. So a mutation that would affect production of those proteins that are involved in signaling, or even their receptors, could result in abnormality in development of the immune cells. So I'm just going to mention a few examples just to try and put that into context, and I'll start with severe combined immunodeficiency. As we mentioned, this would affect both the T and the B cells. So you can either have, the first one here is a situation where you don't get development of or further differentiation of the hematopoietic stem cell either into your common myeloid progenitor or common lymphoid progenitor. So that's what we call reticular dysgenesis. Definitely, there'll be no development of your lymphoid cells or any other cells, and that will present as an inborn error of immunity. The second defect can be something that interferes with differentiation of the common lymphoid progenitor or maturation of the common lymphoid progenitor. So you don't get your pre-B or your pre-T cells. One of the things that can cause this is a deficiency of adenosine deaminase, which will lead to interference with purine metabolism. So you get toxic metabolites accumulating in these cells and they die because of that. So you don't get maturation of your lymphocytes, either B or T. The other thing is one of the enzymes that is involved in the rearrangement of the B cell receptor and the T cell receptor, which leads to maturation of the B and T cells, can be defective. So that's the recombinase activating genes. So if you have a mutation that affects that, then you don't get development of your B or T cell receptor, and you will not get a functional mature B or T cell. We can also have mutations that affect the common gamma chain of the cytokine receptors. And so it's a common gamma chain, meaning this chain or this protein is encoded or seen on or is encoded for various cytokines like interleukin 2, 4, 7, 9, and so forth. And remember, for your cytokines to be able to perform their function, they need to act via their cognate receptor. So if you have an abnormality with that, you don't get further maturation of these cells. And then another defect could be a mutation in the CD3 chain. Remember, the CD3 chain is one of the molecules that is produced when you have your T cells maturing within the thymus. So if you don't get your CD3 chain or you get disruption, this interferes because this acts, it's a co-receptor for the T cell receptor. They act in concert. So this interferes with signaling through the T cell receptor. So there'll be a T cell deficiency. So this just goes to show that SCID is not one disease. There are several diseases, and there are more genes than the ones I've shown here that could be defective, leading to a SCID. And the phenotype will be dependent upon the gene defect. So the phenotype, as I mentioned, SCID will be defined by the T cell numbers. So T cell numbers are always low. B and natural killer cell numbers can be variable. When it comes to primary antibody deficiencies, an example can include a mutation in what we call the Bruton's tyrosine kinase gene. Remember, the tyrosine kinases are now the intracellular molecules that are involved in signaling by cells, for example, the immune cells. So if we don't have, if we have disruption in that signaling, these cells get arrested at the pre-B stage, so they don't mature into functional B cells. So definitely if you don't have B cells, you don't get plasma cells, you don't get antibody production. And this is an X-linked disorder, X-linked gamma globulinemia. The other one I want to highlight is a transient hypogammaglobulinemia of infancy. And this figure is just showing us, summarizing for us the transplacental transfer of IgG from the mother to the fetus, usually during the late second and the third trimester, peaks just before birth. So at birth, usually the infant or the neonate will have high levels of IgG, but this is usually maternal IgG, and it takes time for the neonate's immune system or the infant's immune system to become functional and for them to start producing their own IgG. So sometimes this process can be delayed, leading to low immunoglobulin levels in the infant. The thing is that this usually is a retrospective diagnosis. It cannot be made before 2 years of age. And then these are the other antibody deficiencies. So specific isotype deficiencies like IgA deficiency or the IgG subclass deficiencies. Another one that I want to highlight is the hyper-IgM syndrome, where there's a defect either in CD40, which is a co-receptor or a receptor that is found on your B cells, and the CD40 ligand, which is found on the T cells. So remember, to activate, for a T cell to activate your B cell, or even just for a T cell to be activated after antigen presentation. So this would be the antigen presentation where you get your MHC. Remember, B cells are also antigen presenting cells, presenting antigen to the T cell receptor. And now we want the T cell to activate the B cell so that it can switch the isotype of immunoglobulin that is being produced. Usually the default immunoglobulin produced by a B cell, once it engages with antigen or is activated by antigen, is IgM. So this is usually what happens in the germinal center that leads to isotype switching, affinity maturation. You get all the good quality antibody that we want. But just antigen presentation on its own is not enough. We need this second signal. So a defect in either the CD40 or its ligand, or a mutation in those would interfere with this second signal, and then we don't get T-dependent activation of the B cells. So here there will be no class switching to IgG or IgA, and usually the patients will have very high levels of IgM. That's why it's called hyper-IgM syndrome. But without class switching, they also don't get long-lived plasma cells, so they don't have long-lasting immunity. Remember, IgM doesn't have a long half-life compared to IgG. So IgG is what is responsible for giving us long-term protective immunity. I've already alluded to the phagocyte defects. For example, the leukocyte adhesion defects, where they're not able to roll and marginate and then exit the vasculature for them to go to a site, for example, in the tissues where there's a microorganisms. So these patients tend to have deep abscesses. They have very high neutrophil counts, for example, when they have an infection, but you don't get these neutrophils going to the site of infection to get rid of the pathogen. And then these are the other conditions, for example, reduced oxidative killing as seen in chronic granulomatous disease. I think this is the last one I want to highlight, the Mendelian susceptibility to mycobacterial disease. So here you have gene defects that interfere with the intracellular signaling pathways, the cytokine signaling pathways that are involved in activation of your macrophages by the T helper 1 cells. And usually this is seen or an important mechanism for killing of intracellular pathogens like mycobacteria. So it could either be interleukin 12 or interleukin 23, so defect in the protein itself or its receptor, and this usually acts on the T helper 1 cell, which now produces interferon gamma that activates the macrophage to kill better. So also a defect in the interferon gamma pathway, for example, the receptor itself. This is, I think, gaining a lot of interest in Africa. These patients tend to present with increased susceptibility to infections by non-tuberculous mycobacteria. They can also present with disseminated BCGosis, for example, after vaccination with BCG, which is a live attenuated vaccine. Spectrum of infection is not limited to mycobacteria. They may also get some bacterial infections and some fungal infections like Candida. So the features of inborn errors of immunity, we've talked about increased susceptibility to infections. These infections are usually abbreviated as PAS, so they're severe, persistent, unusual, or recurrent, but it's important to remember that they may also have non-infectious manifestations. So that these are patients who do not necessarily always have to present to the infectious disease pediatrician or to the physician. They may present to other specialties. So they may present to, for example, gastroenterology, if they have like recurrent or chronic diarrhea or inflammatory bowel disease. They may present to hematology, they may present to the rheumatology, to the allergologist, and so forth. And the type of infection usually varies depending on the underlying inborn error of immunity. And so usually the type of infection can give a clue as to what component of the immune system you should be evaluating. So for example, antibody deficiencies tend to present mainly with infections by bacteria, especially the encapsulated bacteria. Remember, the capsule is one of the pathogenicity factors for the bacteria because it enables it to resist phagocytosis. So antibody usually would opsonize this bacteria to basically facilitate phagocytosis. So if you don't have the antibody, then you don't have opsonization, and these patients tend to present with these infections, mainly Streptococcus pneumonia and Haemophilus influenza. They may also have giardiasis and infections with enteroviruses. Most of the infections tend to involve the respiratory tract and then the gastrointestinal tract. For the combined immunodeficiencies, because here both the B and the T cells are affected, they can present with a myriad of infections from the different classes of pathogens. And this tends to mimic what we see in advanced HIV or in AIDS. So they also have the opportunistic infections. For the phagocytic defects, these patients tend to have skin abscesses or infections within the reticuloendothelial systems or abscesses in those systems, for example, infections in the bone marrow, infections in the liver, in the spleen, and so forth. For those with chronic granulomatous disease or MSMD, as I've mentioned, they'll tend to have non-tuberculous infections. They also have, because one of the phagocyte defects is a defect with oxidative mechanisms of killing, then they may also present with infections by catalase producing bacteria like Staphylococcus aureus. For complement deficiency, what's well defined is deficiencies in the late components, which predisposes patients to Neisseria infections. It's unusual that one would have both antibody and complement deficiency, but remember, complement also acts as an opsonin. So sometimes these patients may also have recurrent bacterial infections. So when it comes to the diagnosis of inborn errors of immunity, the history and physical examination are very important. And I really won't go into the details of this because Dr. Migoa will take us further through the diagnosis, but there are certain clues that should always be sought. For example, history of recurrent infections, positive family history. We've seen from the South African PID registry where there's positive family history in 30% of the cases. And then there are what we call the 10 warning signs or the red flag signs as seen by, actually seen on this table that I'm showing here. This is adapted from the Jeffrey Model Foundation. And these signs are based on expert opinion, okay? So the Jeffrey Model Foundation is a foundation that was formed by this family that had a child with a primary immunodeficiency, and they do a lot of work on primary immunodeficiency. So the warning signs apply to both children and adults. They may be slightly different. What I've highlighted here is what has been shown from this study by Subarayan and the team to be the most predictive for primary immunodeficiency in a child. So failure to thrive and need for intravenous antibiotics to clear infections. But all this should be taken into consideration. Of course, especially in our setting, we need to rule out secondary causes like HIV. So if you have a patient present, and I mean, fitting this picture, you still need to think about what occurs more commonly. So rule out HIV, rule out malnutrition. Malnutrition is the most common cause of secondary immunodeficiency worldwide. And other things that may cause an immune deficiency, like immunosuppressive medications, protein-losing conditions, and so forth. When it comes to lab testing, this usually follows a tiered approach. We'll look at this tomorrow. So usually there'll be screening tests, which now the results of which should guide the definitive or molecular test. The principles of management, so the approach would be both supportive and specific treatment. So supportive treatment, of course, the main thing we want to do is prevent infections. We've said these patients are at increased susceptibility for recurrent infections. So usually they would need to be on prophylactic antimicrobials. The specific drugs will may be different depending on the underlying immune defect. Whenever there's an infection, this needs to be treated promptly and aggressively because these infections tend to become complicated very quickly, and you want to try and prevent complicated infections that lead to end organ damage. It's also important to consider nutritional support. So there are micronutrients that are important for immune function, like vitamin D, vitamin A, and zinc. Any patient that requires transfusion, for example, if you're talking about a bone marrow failure patient, you need to irradiate those blood products because you want to prevent graft versus host disease. Vaccination is important, of course, because that helps us to prevent infectious disease. But in some of these patients, you'd want to avoid live attenuated vaccines. So these are patients with either T-cell deficiencies or severe immunodeficiencies like SCID, or when there's a family history of a severe immunodeficiency in a neonate or an infant, we avoid the live attenuated vaccines until we're sure that this child has a functional or is immunocompetent. For those with antibody deficiencies, because they tend to present with recurrent respiratory infections, they may end up having end organ damage, things like bronchiectasis, even if it's not showing physically. So pulmonary status and function has to be assessed. Any other underlying conditions would need to be treated, whether it's an autoimmune disorder or a lymphoproliferative disorder or malignancy. And it's ideal that patients are referred for specific treatment. Supportive treatment also goes into lifestyle changes to prevent infection. So things like hand washing, we've seen the importance of hand washing with COVID-19, avoidance of sick contacts or exposure of these patients to sick contacts, compliance with medications and clinic visits, nutritious diet and exercise. And all this means that these patients need a lot of counseling and support. And if it's young children, even the caregivers do. And it's been shown that patient support groups are also very beneficial. And I'm happy to report that we do have a Kenyan patient support group. It's called the Primary Immunodeficiencies Association Kenya. And these are the details of the patient support group. So if you come across any patients in your practice, I think it's important to try and link them up with the patient support group. So specific treatment will depend on the underlying defect. I think we'll discuss more of this on Thursday. But for example, for the antibody deficiencies, most of the time, replacement of the missing component may be enough. So things like lifelong immunoglobulin replacement therapy, either intravenous or subcutaneous. For severe combined immunodeficiency, it's not compatible with life. So there needs to be immune reconstitution by hematopoietic stem cell transplant. But there's some, remember we said this is more than one disease, there's some for which gene therapy is available or even enzyme replacement like an ADA's kit. For the phagocytic defects, sometimes just cytokine replacements, for example, interferon gamma may suffice if that is where the defect is. So the prognosis will also depend on the type of inborn error of immunity. We've seen some are more severe than others. as well as other factors like the age at diagnosis, the presence of infections. Of course, you'd want to catch these patients before severe infections with complications sets in. So presence of complications and comorbidities like lung disease would portend a worse prognosis, and also the age at the time of definitive treatment. For example, as kid neonates who's picked up, for example, from newborn screening and undergoes hematopoietic stem cell transplant will have a better outcome than one who undergoes HSCT once they've already had a couple of infections. So early diagnosis is important for treatment to prevent complications, and if we can achieve that, then these patients can achieve a near normal life expectancy. So I just want to take the last few minutes, I hope I'm not over time, just to mention that the things that we can do to enable us to identify the patient with an inborn error of immunity. Remember we said it is thought that 70 to 90% of patients are actually walking around undiagnosed, or they're even ill, but we don't know that they have an inborn error of immunity. So one of the things that we need to be aware that they exist, and that is where the A project comes in. We just want to educate, we want to create awareness so that people are always thinking about these conditions. Even if they're rare, it doesn't mean that the patients you're seeing cannot have an inborn error of immunity. We need to know the red flag signs, so things like the family history, early infant losses due to infection, the characteristic of the infectious disease, so the spine infection, the fact that these patients always require IV antibiotics, and failure to thrive. And then the other thing is to know the sentinel organisms. I won't go into details of this. I'll just highlight some things. So infections with encapsulated bacteria, pneumocystis jirovecii pneumonia in a HIV negative patient should be a red flag. Recurrent staphylococcal infections and deep abscesses. I think the other one that I really want to highlight is infections with live vaccines, because I think we've had 2 patients in Kenya who've succumbed to one disseminated BCGiosis and one to had complications from the time they received the rotavirus vaccine at 6 weeks. The other things we can do is know which tests to order, and most of these tests are not cheap, so we need to rationalize, and it needs to be done in a stepwise manner. And then sometimes you may have incidental findings, laboratory findings, which should be interpreted in context, and one should consider an immunodeficiency. Things like lymphopenias, thrombocytopenias, there's some immune deficiency syndromes that are associated with thrombocytopenias, and it's actually been shown that sometimes ITP in itself may preclude or present before an actual PID becomes clear. So one shouldn't just think it's ITP and not try to rule out anything else. If you perform your liver function tests with total protein and albumin, it's always good to look at the serum calculated globulin fraction. This has been validated in some countries as a screen for a hypogammaglobulinemia. It's one of the things I want to do at Kenyatta. So low immunoglobulins, high IgE, because that may preclude a hyper IgE syndrome. For the pathologists, if you're looking at a lymph node biopsy that doesn't have germinal centers, you should ask yourself a question. Failed vaccine responses. I know sometimes you say people are non-responders, but are they really not responding because that's physiological, or is there an underlying immune defect? And then the other thing is that we should aim to identify patients prior to onset of clinical symptoms. This is where newborn screening comes in. I don't think this is done as a public health approach in many countries in Africa. In the US, for example, newborn screening for SCID is performed in all states for all newborns. However, this is available. I know it's available in South Africa, though not for every newborn, but the test is available if you're suspecting. Or for example, if there's been a family history of a severe SCID and there's a newborn, then this test can be performed. And I think this will be mentioned tomorrow. And then we should always aim to make a definitive diagnosis. And this is usually either by genetic testing or functional. There may be some functional testing that can be done that is not really genetic testing, but it's molecular testing. The reason why this is important is it actually now establishes or confirms the suspected diagnosis. Remember, we said the conditions are actually genetic disorders. So the only way you can confirm what it is by knowing what gene mutation there is. And this can help with counseling in terms of predicting future risk, depending on what the gene defect is and the pattern of inheritance, and informing decision-making on reproduction, and also guides in seeking the most appropriate therapies. There's an option of the gene therapy for some of these defects. The other thing that we can do to identify more patients is pre- and postgraduate training in clinical immunology. I know we don't really have clinical immunology as a distinct specialty, but because these patients can present in several different specialties, ensuring that we are passing on this information during training of our health workers will help towards this cause. Access to care, and it's important to have like centers of excellence or centers of care for PID. And we're currently in the process of registering 3 centers at KNH, the Aga Khan University Hospital, and Gertrude's Children's Hospital. So most of the members of the A project from Kenya are actually situated in those 3 hospitals. The other thing is the need to establish a registry. I think each of the members of the A project team has like a small, like a rudimentary registry that they're collecting information on the patients that we have. But it's good that we have a national registry that brings a database that brings all this information together, because that enables us to know the prevalence in our country, the spectrum, what kind of diseases are we seeing, and how can we treat them, would help with research, lobbying, for example, for things like immunoglobulin availability and so forth. So in summary, inborn errors of immunity are more common than previously thought. And it's thought that the worldwide prevalence is 1 in 1,200. Of course, there are some regional differences. It's important to increase awareness so that we can identify patients early, initiate treatment to prevent complications, end organ damage, or premature death. The other thing to remember is the clinical presentation is variable. Usually there'll be increased susceptibility to infections, but there may be other conditions like allergies, autoimmune conditions, and so forth. And because we are in the context of a high prevalence of infectious disease, we still need to interpret the manifestations of these patients in that context. Finally, when it comes to treatment, it needs to be individualized. There's no like one treats all. So this needs to be individualized for each patient. Patients need to be monitored. And we need to think about creating a registry to capture data on what we have in our setting, and to include patient perspectives. That brings back the patient support group. I guess once the patient support group is really grown, we need to listen to what they tell us in terms of their experiences with care. Thank you.
Thank you very much, Dr. Barasa, for the informative discussion. Thank you for the nice presentation. I'll move quickly to the next presenter. Our next presenter has a big CV, but I'll briefly introduce her. Dr. Angela Migoa is an associate professor and pediatric rheumatologist in the Department of Pediatrics and Child Health at the Aga Khan University Hospital. She completed a postdoctoral fellowship at the pediatric rheumatology at the McGill University Health in Montreal, Canada, and holds a master's in pediatrics and child health. She is the chair of the Pediatric Society of the African League Against Rheumatology Task Force Working Group, which is mandated to oversee and advocate for pediatric rheumatology in Africa, and also the National Vice Chair of the Kenyan Pediatric Association. Dr. Migoa, over to you.
Thank you so much, Dr. E, for the kind introduction. Thank you also, Dr. Barasa, to you and the entire team at University of Nairobi for putting together these sessions. And also thank you, Dr. Barasa, for the great talk. I want to honor and commend each and every person who has logged in. Thank you so much also. So I'm going to talk about the clinical spectrum and a phenotypic approach to primary immunodeficiency diagnosis in Kenya. And this is going to be a shift in the gear because I'm going to focus more really on the clinical approach. I hope I'm clear, and are my slides visible?
Yes, they are. You can continue.
Okay, thank you. Okay, all right. I'll begin with a quote by our Nobel Peace Prize winner, and she said that in the course of history, there comes a time when humanity is called to shift to a new level of consciousness, to reach a higher moral ground, and a time when we have to shed our fear and give hope to each other. And that time is now. I think that's the essence of what we are doing as members of the A project, because sometimes these entities are so confusing, but we hope that after this, we'll be able to shed our fear of these entities and give hope to the patients that we serve. So the objective of my talk is to really highlight the clinical spectrum of primary immunodeficiencies that we have observed in Kenya. This will be the outline. We'll have a brief overview, and I won't deliberate so much on that. Dr. Barasa has done a phenomenal job. Then go straight into case presentations, thereafter have questions and summarize. So Dr. Barasa has gone into quite a lot of depth to expound on how the immune system works. And for me, I think I'll summarize it in two phrases: the ability to identify and respond appropriately. And when those two fundamental functions are interfered with, then your immune system fails. If it has an excess response, then we as rheumatologists, we come in, for example, with autoimmune conditions. And when you're not actually responding appropriately, not responding in a good effort or in good time, then your issues like primary immunodeficiencies do come in.
Dr. Ligawa?
Yes.
Do you mind putting your slides on slideshow kindly?
Oh, sorry. Oh, my goodness. My apologies, Dr. E. Let me do that from current slide. My apologies. Okay. Not sure why it's hanging. Yeah. Is that okay now, Dr. E?
Perfect. Continue. Thank you.
Good. My apologies for that. So when it comes to the clinical spectrum, and Dr. Barasa actually touched on this a little bit, we have got different components of our immune system. What we used to call initially the well, it's still called the innate immune system, phagocytes, complements, and natural killer cells. When this section is not functioning appropriately, there are certain entities that we see. For example, you could have congenital neutropenia, chronic granulomatous disease, or leukocyte adhesion deficiency as a complication if your phagocytes don't work well. If, for example, the natural killer cells don't work well, this is because sometimes there's a transcription factor called GATA2 that's responsible for its functioning and doesn't work well. When your B cells do not function appropriately, and Dr. Barasa has touched on this, you could have entities like hyper IgM syndrome or specific antibody deficiencies. If your T cells don't work well, you could have severe combined immunodeficiencies. So this is just a list of some of the entities we would see when the different components of the immune system are affected. There was a slide. Another very important slide I feel is that because most of the time we see the patients with the different presentations or manifestations. So if you see a child who's always having recurrent respiratory tract infections with encapsulated bacteria, and this is why working hand in hand with the pathologist is very important, you begin to wonder whether the B cells have a problem. If you see a child who's always having fungal infections, severe viral infections, you've ruled out things such as HIV, for example. In medicine, we say commoner things occur more commonly. If you see that, then you begin to wonder, is there a problem with the T cells? If you find a child who's always having recurrent skin abscesses, lymphadenitis, and you're actually able to isolate catalase positive pathogens, or for the newborns, there's a delayed umbilical cord separation, then you wonder whether there's a problem with the phagocytes. If you find a child again who's always having recurrent infections with encapsulated bacteria, or for us, if I start seeing a child who is 2 years old with lupus or recurrent, for example, Neisseria infections, then I wonder about complement. If I find a child who's always having recurrent herpes or increased malignancies, you wonder about natural killer cells. So that's why if you're able to get a lab support that can help identify these pathogens, it's actually very helpful. Dr. Barasa talked about some of the warning signs that we in the, on the clinical side might come across. And if you do see these, then you need to wonder whether this child possibly has a primary immunodeficiency. For example, if they have 4 or more ear infections in a year, 2 or more sinus infections in a year, 2 or more months of an infection with antibiotics having a very little effect, 2 or more pneumonias in a year, failure to thrive, poor weight gain, recurrent deep-seated organ abscesses, persistent thrush. Surely if you see a child with thrush from January to December and you've ruled out things like HIV, then you need to wonder whether they possibly have a primary immunodeficiency. Or if they're always needing intravenous antibiotics to clear infections, again, that is a red flag. 2 or more deep-seated infections, and very important also is a family history of primary immunodeficiencies. When it comes to the evaluation, and Dr. Barasa has highlighted this, and we're going to talk about it, I think, in more detail in the subsequent sessions in the week. You can think of it in 3 arms. One is a quantitative analysis, and I must tell you, for me, one of my favorite tests in this bracket is actually the full hemogram, and we're going to look at that. And for the different types of cells that could be afflicted in the respective primary immunodeficiencies, you can see some of the investigations that you could do. So once you have ascertained that the quantity of those particular cells is appropriate, then you go into functional analysis. And again, there are many things that you could do depending on the different cells that you're targeting. And third tier is actually genetic testing, because sometimes you might have to go this way to narrow down on a specific diagnosis that you're talking about. So now we'll actually go into cases, and these are cases we have encountered here at home in different facilities across the country. So the first case was a 7-month-old girl. And it's reported since birth she's been having recurrent fevers. And she was sent to me as a rheumatologist because she had this swelling of hands and feet, oral ulcers. So the pediatrician who was seeing her was concerned about the possibility of her having a rheumatological diagnosis. Well, now we took more detailed history. From day 3 of life, she had a fever of 40 degrees centigrade. They initially thought it was neonatal sepsis. I think cultures were negative. Day 5 discharged. Day 21 readmitted again because she had fever. Mom is not, she didn't have records for me to know exactly where they thought the infection was, but she was admitted for 5 days of inpatient management with antibiotics. And since then, every month, she has about 1 to 2 episodes of fever lasting 2 to 3 days. And she's always getting antibiotics as an outpatient. Somebody somewhere along the line tried some prednisone syrup, which relieved symptoms temporarily, but the fevers kept persisting, and mainly in the evening. And the last episode of fever she had before she actually came to the rheumatology clinic was a febrile episode associated with an exfoliating rash. So for me as a rheumatologist, I was now beginning to get excited about what we call the autoinflammatory syndromes or periodic fever syndromes, where people are always having fever even without infection. When it came to the birth and developmental history, mom had preeclampsia. She was born by CS due to a non-reassuring fetal status. Of concern was her birth weight was on the lower side of normal, 2.8. And currently, by the time I was seeing her, I remember she was 7 months. She was 5.9 kilos. So she was still not keeping to the road to health. For her nutritional history, her diet mainly consisted of pumpkin, bananas, and spinach. There was no known allergy. As rheumatologists, we always ask about night awakening because it's always a red flag for malignancies or infection, but that was not present. And she just never wanted to be covered. for the family social history, which is also a very important component when you're managing patients you suspect could have primary immunodeficiencies. So they were living in a slum area and she had siblings who were well. Dad worked in a bus company. There was no consanguinity, which is an important negative. And also there was no infantile deaths, which is also another important negative. However, the child had two paternal aunts who had sons with recurrent fevers, but both of whom were now well. When we examined her, she was very alert and interactive. She had a bit of hypopigmented rough skin rash. She had oral sores and thrush. And indeed, when I examined her, she had dactylitic fingers with a couple of joints that actually had arthritis, including the midfoot. So at that juncture, some of the concerns I had with this child as possible differentials with either primary or secondary immunodeficiency, autoinflammatory syndromes, which is our bread and butter, vasculitis, I thought about sarcoidosis, or even a metabolic storage disorder. So we started our investigations. And what I've projected there is not for you to try and cram everything, but just to show you, to share with you some of our rationale of why we did what we did. I told you one of my favorite tests is actually the full hemogram. And what I've highlighted in red is what was actually abnormal. So everything else you see on that slide was actually normal. So she had a low HB, and actually it was a normochromic normocytic picture. Sorry, I should have put the MCV there. Her platelets were a bit on the high side. I was worried whether she could possibly be having early onset lupus, which would be an indirect indication of possible complement deficiency, but those antibodies as illustrated by the ENA antibodies were negative. Remember, one of my concerns was a vasculitis, so that's asked for this antibody is negative. Remember, in medicine, commoner things occur more commonly. HIV was negative. I wondered about a B cell immunodeficiency, but her immunoglobulins were actually fine. I was concerned about sarcoidosis, so her ACE level was fine. We still looked for other possible causes of infection. We did a Torches screen, negative, blood culture, urine MCS, negative. The other thing that we could see sometimes with primary immunodeficiency is an entity we call a macrophage activating syndrome, or sometimes the hematopathologists call it hemophagocytic lymphohistiocytosis. And for that, what normally happens, your lipid levels are high, ferritin is high, but for her, all these were normal. I was also wondering, okay, could we be sitting also on possibly some sickle cell? But it was not really in keeping because symptoms started so early, which is not typical for sickle cell. But either way, that was normal. So remember I had said that her weight was actually below what was expected for age. And so for that, we had already called on board a nutritionist so that we were managing her also for malnutrition, following the 10 steps for malnutrition. But as we were working her up on that aspect, we did the bone profile, her vitamin D level was low, so we supplemented that. And we were still concerned about possible autoinflammatory syndromes. So fortunately, we were able to get the welfare support from the institution where I work, and they were able to support this. And we were looking for genes that predispose her to what we call periodic fever syndromes. That came back normal. We did flow cytometry for the B cells and T cells. That came back normal. So the only thing I was able to do for this girl was to optimize her feeding, give her fluconazole for her thrush, and some painkillers because I could see she did have arthritis, and of course optimize her vitamin D. So we reviewed her, again 2 weeks post-discharge, and she gained weight, 600 grams. Mom was very compliant, and the nutritionist actually did a follow-up with the mother at home just to make sure that what the plan agreed in hospital was actually being implemented. And we continued reviewing her actually for about a year. She kept coming back, and her weight gain trajectory just improved. She only had 1 more episode in a whole year because of a URTI, and her symptoms completely resolved. What was our final diagnosis? This child probably had an immunodeficiency secondary to malnutrition because our workup for autoinflammatory conditions was negative, and the main intervention that we did was feeding this child And in 1 year, she only had 1 episode of fever. Dr. Barasa touched on this, and I will emphasize it again, that malnutrition is still the leading cause worldwide of immunodeficiencies. And the amazing thing is that this is something that we can fix as pediatricians, as general practitioners. So it's something do not overlook, because we can intervene and we can save these children unnecessary antibiotics and unnecessary hospital visits. And this is, again, another topic which I'm very passionate about, immunometabolics, because this really highlights the intersection between nutrition and the immune system. And how I normally explain it is like, today you could have a fighter jet, you could have a Probox, you could have a Mercedes-Benz, but all those means of transport, they all need fuel to move. Without fuel, they cannot move. So your immune system and the components of your immune system is something similar. You can have all these cells, T cells, B cells, phagocytes, but without energy, they cannot function. And that is where nutrition plays a really key role. And this table just shows some of the energy functions that might not be optimum in the neonates. And of course, there are many other reasons why neonates are always susceptible to infection. This is just one of them. And you can see as you grow older, when you're more tolerant, your immune system is more tolerant, you can see most of these energy levels are down. But in the face or in the event that you face a pathogen, then some of these energy pathways go up. For example, glycolysis goes up, fatty acid synthesis goes up, fatty acid oxidation goes up. So it's a very fascinating field, and we can always discuss it in another forum. The second case, this was a 6-year-old female admitted on the 31st of May, 2017, discharged on the 6th of June, 2017, but unfortunately succumbed the 9th of November, 2017. So she presented with fever and chest pain for 2 days, and she had left-sided pleuritic chest pain with fever of 39, not 390, 39 degrees centigrade. And she was on follow-up for bronchiectasis and was on home oxygen. Going back into the history, and why I'm doing this is to really emphasize again to all the participants that nothing will ever replace history, because from there you can get a lot of information to guide you as to how to intervene for these children. So at 5 months, she was assessed because she had query nail pits. And during the evaluation, somebody felt that she had a chest infection, and she was treated with a course of ceftriaxone. In 2012, 2013, she had 2 admissions for fever and difficulty breathing, and each of these resolved with intravenous antibiotics. She also had this widespread boil skin infection that always required admission for intravenous antibiotics. And if you recall, in some of the 10 danger warning signs, when you start seeing people always needing intravenous antibiotics for their infections to settle, that is potentially a red flag. 2014, she was asymptomatic. 2015, again, she had this recurrent cough, and somebody suspected, okay, it could be TB. She was put on a trial course of anti-TBs, but really her symptoms never resolved. In 2016, she had 3 admissions for chest infections. However, we did not get information as to what were the pathogen isolates, what antibiotics were given, and the duration of therapy. And I'm sharing this because we know we come from different fields, and sometimes in this kind of patients, it's really important to know what isolate was there, if possible, because I know it's not always possible to get the isolates, and to see what kind of antibiotic was given. Was it an optimum dose, and was it for an optimum duration? So we didn't have that information. 2017, 3 admissions for chest infection, no pathogen isolated. However, she had eczema since birth, no known allergies, and she was on neurology follow-up for developmental delay. It was also seen physiotherapy, occupational therapy to help with that developmental delay. She was on follow-up by the pulmonologist for her bronchiectasis, and there was a history of delayed dentition. When we did the functional inquiry, this is another very important aspect of the history where you're looking for symptoms from head to toe to try and give you a clue as to what you might be dealing with. And what came out that was significant is that she had stagnant weight for 1 year, and she had this deep pigmentation of the hair, the face, and the pubic area for a year, no lymphadenopathy, cardiovascular, gastrointestinal, genitourinary systems were fine. As a rheumatologist for the joint musculoskeletal system, there were no issues. As regards the pregnancy and perinatal history, she was one term via assisted vacuum, and the weight was actually good. Unlike our previous case, where the initial birth weight was low, but this one, the weight was good. There was no exposure in the pregnancy period to any potential toxins. However, in the immediate neonatal period, she was admitted to nursery for about 3 days because she presented with what was suspected sepsis and then discharged home. For the family social history, and this always gives like an indirect indication of possible genetic conditions and the pattern of her inheritance. So she was the third born. She had a 23-year-old brother who they shared the same mother, different father, and a 13-year-old sister who they both shared parents, and both were alive and well. The parents were separated. However, there was no history of consanguinity and no history of any chronic illnesses or similar ailments or even infantile deaths. When we examined her, the vitals that are in red is what was abnormal. On room air, her oxygen saturations were 74. But then when she was on oxygen supplementation, that would pick up. But what was very keen and interesting is that she had this very sparse, brittle, silvery hair. And she had this a very rough, thickened skin, suggestive of long-standing eczema, which we had gotten from the history. And indeed, she had depigmentation over the forehead, torso, and pubic area, no lymphadenopathy. She was a bit dysmorphic because she had this widened epicanthal distance, and she had poor dentition with some missing incisors. She had this global hypotonia. Remember we said that she had this developmental delay. And for the respiratory system, she had this harsh breath sounds, pes carinatum, but when on oxygen, she was not in distress. And what was another important finding is that she had hyperextension of her proximal and distal interphalangeal joints, but there was no arthritis. This is not the picture of the child, but this child represents almost what we saw. You can see this depigmentation here on the eyebrows and almost this silvery hue-like tone of the hair. Something like that is what our patient had. So the differential diagnosis at that time, we wondered about congenital immunodeficiencies, and the list is as listed there: inborn errors of metabolism, cystic fibrosis, or interstitial lung disease. When we did our workup, remember, commoner things occur more commonly. So it's important to do due diligence to rule out things like HIV and TB when you suspect these things. When we're worried about possible immunoglobulin deficiencies, but that was normal for her. The neurologist was on board, did a brain MRI to look for any structural abnormalities, but they didn't find any. At that time, there were also concerns whether she could be having some occult CSF infection, and so a lumbar puncture was done. You can see the proteins were actually high, but the Z and stain and culture were negative. Gene expert was negative. Stools, blood, sputum culture is negative. Again, I was concerned, could she be having early onset lupus is a possibility here, but some of those autoantibodies were negative. And this is just a table showing you the full hemogram trend. I told you it's one of my favorite tests. And, it's not to remember the numbers, but really the trend. In some of these chronic diseases, what we keep emphasizing is one value is important, yes, but look at the trend. And the values highlighted in red is what was abnormal. You can see overall her neutrophils were a little bit on the high side, but her lymphocytes were always on the lower side of normal. Her MCV, MCH was always on the lower side of normal. HB, relatively lower side of normal. I'll show you the next table. Again, similar trends. And so to summarize this full hemogram report, she had this persistently elevated white cells, especially in neutrophilia. She had an iron deficiency anemia, a low eosinophil and lymphocyte counts, but normal liver function tests. So when you see that, one of the things in the backdrop of this silvery depigmentation of the hair and of the skin, then you think of Griscelli syndrome. And Griscelli syndrome is one of the primary immunodeficiencies where you actually have an abnormality with some of the DOC proteins. You know, the immune cells, as they function, when they move to respond, remember I said immune cells, they have to serve two functions: one, to identify the problem, and to respond appropriately. So when the immune cells identify a problem, assuming they identify correctly, they need to respond. And when they respond by releasing various cytokines, lytic enzymes, but these components are not just floating within the cell, they are actually encapsulated within, you know, very well-defined compartments. And for the cell to respond, then most of these well-defined compartments have to like attach or blend with the cell membrane and release their components to execute the effector function. So that is actually mediated by various DOC, we call them like DOC proteins, and that includes like RAP27A protein, melanophilin protein, myosin VA protein. And depending on what is abnormal, all right, you can have three different types of Griscelli syndrome. When you have the myosin VA DOC protein affected, then there's neuronal function is compromised. When you have the RAP27A DOC protein affected, you have a problem with exocytosis of your cytolytic granules, okay? And that gives what we call type 2 Griscelli syndrome, which is what we think our patient had. And you can see when this gene, there's a problem with that gene, it's mutated, you cannot transport melanin in your skin and hair, and that's why they have this depigmentation or this silvery hair, what they call partial albinism. And because your lytic granules cannot be able to release their components because the DOC protein isn't there, then you find that you're susceptible to infections. And when these infections are uncontrolled, you can end up having hemophagocytic lymphohistiocytosis and other neurological defects. So this patient was treated with antibiotics, after which fevers resolved. She was discharged home on prophylactic Septrin to try and help prevent her catching other infections. The chest team, pulmonologist, prescribed Ventolin Seretide, but unfortunately she lost the battle on the 9th of November at 6.5 years of age. What could we have done that might have been beneficial? And I think Dr. Barasa touched on this, doing serum albumin globulin ratios. Remember I said one of the risks they fall into is actually having hemophagocytic lymphohistiocytosis, what we call macrophage activating syndrome. And for that to do, triglyceride levels and fibrinogen levels and ferritin levels can actually help you pick this early and intervene early. Microscopic examination of the hair shaft. If you have somebody who's good in this, that will help. Genetic studies, and ultimately, of course, to counsel the parents should they want to have another child in the future. The third case, this was interesting because we've had, this is now going to be the third, possibly a project, but the first as the virtual one, but we've had two others. The first one we had in April 2019, and the second one we had in October 2019. And when we had the A project meeting in October 2019, one of the participants walked up to the team and said that she had a niece who she thought might have a primary immunodeficiency. So the child was actually referred to some of the clinicians in the A project team. So this was a 5-year-old girl with history of skin abscesses and eczema since 6 months of age. In 2019, she had a large abscess that was surgically removed from her nose, and it really left a prominent scar. And on the day she presented to the A project team doctors, she had several cold abscesses on her scalp, neck, and forehead, and she had got these coarse facial features and hypermobility. So the key things, no dental abnormalities, because there are certain primary immunodeficiencies where you can see double rows of teeth or abnormal dentition. She was born to non-consanguineous parents. No history of delayed cord separation. So when you hear that in the history, issues of chronic granulomatous disease moves down on the list of differentials, no delayed milestones, received all vaccines, including BCG, uneventfully. That's a very important thing for us when you're thinking about primary immunodeficiencies. No history of allergies, but had one older sibling, one older sibling and 4 other half siblings, among which 2 had eczema. No infantile deaths. Chest X-ray showed a huge cyst on the left lower side, and the thoracic surgeons, cardiothoracic surgeons, and pulmonologists decided to biopsy this, and the biopsy results showed inflammatory cells, no neoplasia. That was very important for us to rule out. They did ZN staining for AFB negative, gene expert was negative. Other key findings on the investigations is that she had leukocytosis, platelets were high, HB was actually normal, but we did her immunoglobulin profile, and what we found is that she had elevated IgE. And so in collaboration with some of our partners in the NIH, courtesy of actually one of our doctors in the A project team, and I think she'll be presenting more details later, Dr. Lisa, we were able to connect and actually do exomes, genomic sequencing to find out, because when you see hyper IgE, there are many genes that could be afflicted, and they found that there was a mutation in STAT3, and I'll tell you more about STAT3. I apologize if this is not very clear, but most of the immune cells, what happens is that, remember we said there has to be an identification of the problem, whether it is a pathogen or an abnormal cell. And when that identification happens, most of the time, intracellular reactions actually take place that involve phosphorylation. So it becomes like a chain reaction until finally the message gets to the gene, transcription happens, and you can have effector proteins or effector molecules produced. So when it now comes to, let's begin with the naive T cell, all right? As it moves into specialized T cells, you know, for you to be specialized, you have to produce certain cytokines. You need phosphorylation of this intracellular molecule STAT3. When you come to your B cells, when they identify the antibodies and have to produce interleukins, that intercellular reaction requires phosphorylation of this molecule called STAT3 for you to form your plasma cells. When your macrophage is actually mediating inflammation, certain cytokines like TNF, alpha, interleukin-1 need to be produced. But for them to be produced, you need phosphorylation of STAT3. So can you see how catastrophic it is if you have a mutation in STAT3? You cannot have specialized T cells. You will not be able to have specialized plasma cells to produce the specific antibodies. And the first line of defense, your innate immune cells, are not able to effect their function. So you're just gonna have lots of infection. And what did we do for her? So she was treated with flucloxacillin for her skin infections. She was given prophylactic Septrin, given skin emollients, advised on skin care with chlorhexidine baths. And since then, she has remained abscess-free, purely on prophylactic Septrin and skin care. She only needed 1 course of fluconazole for oral candidiasis. And now this is the last case. I still hope that I'm audible and the slides are clear. This was a child, 1-year-old, known to have Down syndrome and had persistent nasal congestion, fever, daily cough for 8 months. So you can imagine symptoms started when this child was about 2-3 months of age and had several outpatient consults, taking lots of antibiotics, and was actually sent to the pediatric infectious specialist for further evaluation. An examination, the child was sick looking, was syndromic, had low set years, had global hypertonia, BMI was on the lower side of normal, even for the chart for the Down syndrome children. The rheumatologist and pulmonologist were asked to review, and we were concerned about a possible primary immunodeficiency, just because since 2 months of age had been having recurrent infections. And when we did the serum immunoglobulin test, it actually showed elevated IgM. And for that, and I think Dr. Ann highlighted that in her slides, you have this entity because you're not able to have class switching to form different immunoglobulins. So I normally say it's like, if you have an army, you cannot just have the AK-47 to fight your opponent. You must have other sources of, or other tools or equipment to fight your enemy. So in hyper IgM syndrome, it's like you only have one AK-47 to fix all your immune problems, which is not feasible. And so what we did, this child was given 2 courses of intravenous immunoglobulin, but as you can imagine, the costs of this has been expensive, so they're not able to sustain, but they continue to follow up with the infectious disease specialist. And this is just highlighting what we talked about in hyper IgM syndrome, that co-stimulation between B cells and T cells is affected, and they are not able now to produce antibodies. And I think that is the end. I think I'll summarize by saying that, a thorough history in this kind of patients is really significant, and a detailed physical examination, and a good place to start your investigations is actually a full hemogram. If you're able to isolate pathogens, then you can narrow down the different investigations to see which immune cell is afflicted. And remember, when all else fails, don't get stuck, call for help. I want to say thank you to all our patients who inspire us to improve and be better healthcare providers. And of course, to all my mentors and teachers, some of whom I can see have logged in, Professor Ndwati, Dr. Gashara, because without them, we would not be where we are today. Thank you so much. I'm done.
Excellent presentation, Dr. Bugoa. And I can see there are a few questions that have been posted on the chat box, but first I'll start with Dr. Barasa. Kindly, in a minute or so, kindly talk about the A project and what the good work the team is doing.
Thank you. Oh, and you're on mute. You're on mute.
Unmute your mic kindly.
Okay, thank you. So as you had mentioned, so the A project is ideally this one-day program initiated by the African Society for Immunodeficiencies to spread the awareness, to educate healthcare providers on primary immunodeficiencies, what they are, how to identify them, how to manage them, just so that we can manage our patients better, identify them early and manage them better. It's been around for quite some time. Kenya is one of the few countries that got onto this train kind of late in 2019. Activities of the A project have actually been going on for some time, from I think around 2014, but better late than never. You can see from what Dr. Migoa presented that already we are picking up more cases just because of the A project. People are starting to think about it. Yeah, I think basically that's what I'll say about the A project. We've had 2 A project events in Kenya. We had one at the Kenya Pediatric Association conference last year, and another one at the Aga Khan in October. So the initial one was in April, and this second one was in October of 2019. And this is the third one that has had a very good reach. At least we've managed to reach around 500 participants, and we're really happy about that. And we just know, tell one person and the word spreads, and we can identify these patients and manage them better.
And sorry if I just may add, I think, and it will be important that we acknowledge Professor Nala Erwa, who is the president of the African Society of Immunodeficiencies. And she came to our KPA meeting in 2018, and she planted the seed of the A project, and everything else is now history. And she was in partnership with Sugania, who I think is also on this call. So they planted the seed, and everything is now history.
Thank you so much for that answer. Dr. Migoa, there's a question for you here, and Benson asks, I have noted out of the case studies, yes, it's similar to children who start their children with Uji before 6 months. So you find those babies have fever now, and then a skin rash, and also Daktari, would you advocate for mothers to give their children Uji before?
Sorry, I lost you. Would I advocate for?
the mothers to give them uji before 6 months?
The answer is no. Don't give your children uji before 6 months. They're not ready to to digest it. You know, the appropriate age for weaning is 6 months. But really, to build up on what the participant has asked, and Dr. Barasa highlighted it, malnutrition is still the #1 reason for immunodeficiency. And so I think we need to do our due diligence to advocate and promote optimum nutrition for our children. And if for sure you've ruled out malnutrition, you've ruled out common things like HIV, you know, TB, then you need to start thinking what else is going on. Yeah.
Thank you. Thank you. Dr. Mweke Simon asks, what's the justification for choice of anti-inflammatory as diclofenac injection has been banned from use by WHO due to its adverse reactions? In one of your presentations, it had been used on one of the, I think on one of the clients.
Yes, that was actually the first case because she did have midfoot arthritis and arthritis involving some of the proximal interphalangeal joints. She had been actually on Brufen, oral Brufen, and that didn't work. In rheumatology, if oral Brufen doesn't work, you can scale up to oral diclofenac. So it wasn't intramuscular. We actually don't use intramuscular diclofenac as pediatric rheumatologists. So that was oral diclofenac. And if oral diclofenac doesn't work, we even scale it up to other anti-inflammatory agents like indomethacin. Yeah.
Thank you so much. I want to give Professor Nduati 1 minute to give her remarks, then maybe we close if there's no other question.
Okay.
Good evening. Thank you very much, Dr. Sturanela. I just first of all want to congratulate the two ladies. They have given us an excellent presentation. I think better than you'd get in an international meeting. I think the fact that we're talking about primary immune deficiency means that we have developed, as a country have developed, we are now reaching out and making diagnosis in children who have these conditions. As Angela, as you presented, I could recall children we managed in KNH who fit perfectly into this diagnosis of primary immune deficiency. And I'm glad that the opportunity for diagnosis and management is available. So thank you very much. And I look forward to the rest of the week. I'm sure we'll learn lots more interesting stuff around this condition. Thank you.
Thank you so much, Prof. As we close, I want our presenters to give us a closing remark, 30 seconds each. I'll start with Dr. Barasa.
Okay, I just want to thank everyone who took out the time to attend this webinar. Learning continues, and I know you'll be agents of change in identifying patients with suspected primary immunodeficiencies. Thank you.
Dr. Migora?
One is to really say thank you to the University of Nairobi for organizing this platform. Thank you to all the participants also. And you know, for some of us in the A project team, this is such a huge milestone because the first A project, we were only, I think, 30 participants, and today we were over 500. I think our goal is to empower each and every one of you with the knowledge to identify these children and initiate certain strategies to prolong their lives. And we are here to support one another. Let's work together. Reach out. I can guarantee you nobody in the A project team will hold back to assist you as you care for the children of this country and the future of our country. Thank you.
Thank you so much. I want all the people on the panelist block to unmute their mics, and I want us to clap for our presenter. So kindly unmute your mic, Dr. Walong, Dr. Mutua, Dr. Mashare, wait, I'm coordinating. Dr. Magutu, kindly. We start 1, 2, 3.
Thank you.
Excellent.
Great work,
so,
guys.
Great work. So as we close, tomorrow's presentation, we have 3 presenters. We start at 7 p.m. Lab approach to diagnosis of PID by Dr. Njagi, then PID case presentation, discussion by Dr. Walong and Dr. Cleophas Mutua. Our moderator shall be Dr. Ali Kasim. Then we shall continue on Thursday. That said, I want to thank the team that attended today. There are more than 530 of us, the presenters, the panelists, and everyone, and our presenters. Dr. Mgoa, thank you very much. Dr. Barasa, thank you so much. So have a good night, people.
Thank you.
See you tomorrow at 7 p.m.
7
Let's
p.m.
make sure we start early. Thank you so much. Good night.
Thank you. Good night. Bye-bye. Thank you.
Thank you very much.
Everyone.
Bye.